Communication, part two. When we're talking about communication in healthcare, there are several different things that we need to look at. We always say that nurses should be assertive. Well, what is assertive behavior? It's the ability to stand up for yourself and others using open, honest, and direct communication. It focuses on the issue and not on the other person. So review those examples on page 197 in the Taylor 10th edition textbook. This has some really good examples on the differences between being assertive, being non-assertive, or being aggressive. We also talk a lot about using therapeutic communication when we're dealing with our clients and our coworkers. Therapeutic communication are specific responses that will encourage the expression of feelings and ideas and convey acceptance and respect. When we talk about intrapersonal communication, this is self-talk or basically communicating with yourself. Interpersonal communication involves communication between two or more people with a goal to exchange a message or messages. Interprofessional communication is communication between members of the healthcare team. We use this when we collaborate on medical care for clients. Handoff or reporting will occur when the responsibility for care is transferred from one care provider to another. It needs to be accurate and complete. This can be nurse to nurse, nurse to other healthcare professionals, such as a provider. And documentation, which is the written or electronic legal record of all pertinent interactions with a client. This includes assessment, diagnosing, planning, implementation, and evaluation, and we obtain this information from interviews, assessments, and diagnostic testing. Effective communication involves being complete. Communication has to be complete. It's going to include making certain that you have all of the pertinent information available before initiating the communication. This is going to save time and frustration on the part of the sender and receiver of the communication. Let's say, for example, you need to call the provider regarding the status of your client. Well, if you just pick up the phone and you call the provider and say, something's going on with my client, they're going to say, well, tell me about it. Have you done an assessment? What are your vitals? So on and so forth. So making sure that you are getting those assessments completed, that you're looking at medical records for diagnostic results, etc. Having all that information at your fingertips before you initiate that call. Communication should also be clear and make sense. For example, the use of the S-bar, which we'll talk about later, is going to provide a template for communication to help make sure that it flows. Communication should also be brief. Nurses and other healthcare professionals are busy. They don't have time for a novel with communication. It's not an English grammar essay that requires paragraphs when we're documenting or full sentences. For example, if you document, the client is alert and oriented to herself, to the time, to where she is at, and to what is going on. She ambulates without difficulty. That provides a pretty clear picture of what's going on, and that's what documentation should be. It is writing down a verbal picture of what's going on with the client. But if you write client A and O times 4 ambulates without difficulty, you are saying the exact same thing. The exact same thing. So we can do documentation very concisely, very briefly, versus writing a whole essay about it. And documentation should be, or communication also, should be timely. In other words, it needs to be done as soon as possible after the client's care and safety issues have been addressed. However, be aware that sometimes, unless it involves client care, uh, needing new orders, we have a change in client status, that type of thing, you sit down to document, it may not be until after your shift is over. That's why it's critical to keep notes of everything that you do, including your assessments, the client's vital signs, administration of PRN medications, changes in the client's status, notification of the provider if you need to call them for some reason, etc. So really important to do this as soon as possible after the actual event, but understand that that's not always possible. So keep good notes. Nurses should demonstrate warmth and friendliness with a pleasant greeting and friendly smile. This should also be continued throughout the nurse patient relationship to help convey acceptance and interest in the client. These are all principles of promoting therapeutic communication. The next principle is the nurse should be open, accepting, never judgmental, despite personal feelings or beliefs. The nurse should be frank and respectful. Nurses are patient advocates, supporting the client's wishes, their desires, their beliefs, whether the nurse agrees with the client or not. You don't have to agree with them to be supportive. The competent client has the right to make their own decisions and choices. Empathy is an objective understanding of the way in which a client sees their situation, identifying with the way another person feels, putting yourself in another person's circumstances, imagining what it would be like to share that person's feelings, and communicating this understanding to the client. The client should also be able to trust that nurses are who they say they are, trusting that the nurses are going to do everything within their level of expertise to help meet that client's needs. Clients are able to discern if a nurse looks at them as a task to be performed or a person of worth who is both cared about and cared for. Clients that feel cared for are going to feel accepted. They're going to be more open and more communicative. Clients will develop trust in and respect for nurses, and this will facilitate a therapeutic relationship and good communication when the nurse demonstrates competence in all aspects of nursing, not just the ability to take care of physical needs, but the ability to be empathetic, the ability to show caring, the ability to be supportive and honest, etc. Building rapport. This is really important for therapeutic communication. Rapport is a feeling of mutual trust experienced by people in a satisfactory relationship and facilitates open communication. Specific objectives will require having a purpose for that interaction, and that purpose will provide guidelines and guidance to achieve a meaningful encounter with a client. The environment should be comfortable. It helps promote interactions. No matter how busy you are, you should never promote a feeling of being busy. You should promote a feeling in the client that he or she is the most important thing at that moment. Privacy can also free the client to share information that he or she may not normally share without it. You can provide privacy by shutting the door, drawing the curtain, or moving to a less occupied area of a room and lowering your voice. Confidentiality. It's important to let the client know what information has to be shared and what information can be kept private. The client also has the right to specify who his or her information can be shared with. Patient versus task. Communication with the client should always focus on the client and the client's needs, not on the nurse. The client is the important person in the room. Observations. Observations. Nurses use all of their senses in the assessment and the interview process and should be constantly observing the client for clues and cues. It increases awareness of a client's nonverbal messages. It can be the major source of communication if the client is nonverbal, and it demonstrates caring on the part of the nurse. It's important in clinical reasoning and clinical judgment. And finally, pacing. Let the client pace the conversation and or let the client know if you have a time limit so the client doesn't feel rushed and they can pace the encounter accordingly. Your time limit will indicate that there's not a lack of interest in the client. So, different skills that we use in therapeutic communication include active listening. Active listening is a conscious effort to fully engage with another person while they're speaking, with the intent of understanding what they're saying and why. It involves being present in the moment and absorbing the information being shared rather than listening to respond. It will keep both the speaker and the listener engaged in the conversation. In other words, as the client is speaking, don't be on your cell phone, going through Facebook, or replying to a text message. Don't be on the computer documenting a ton of information while the client's talking. It makes the client feel like they're unimportant. Using silence. When it's used appropriately, it will allow the client to proceed at his or her own pace after gathering his or her thoughts. It also allows the nurse the opportunity to reflect on what the client said. It will indicate that the client is comfortable. It may indicate the client is stoic or the client requires time to think. It can also indicate being fearful, angry, or it may just be a part of their culture. Touch is a powerful means of communication with multiple meanings. It can provide connection, affirmation, reassurance, and stimulation. It can decrease loneliness, increase self esteem, share warmth, intimacy, approval, and emotional support. But it can also communicate frustration, anger, aggression, punishment, and can invade someone's personal space and privacy. And sharing humor. We know that laughter releases excess physical and psychological energy. It can help reduce stress, anxiety, worry, and frustration, but it is a learned skill. And if humor is used inappropriately, you can destroy the entire relationship. So, exemplars of therapeutic communication include open-ended questions or comments. They will allow the client to freely verbalize and provide more descriptive information. And it prevents the client from answering with just a yes or no question. And to be perfectly honest, when you're taking your test and you come across a communication question, look for the response that is going to require the client to open up and talk and say more than yes or no. A closed question or comment can offer the client limited choices of possible responses. If it's used inappropriately, it can be seen as a barrier to effective communication, but it can center a client by asking for specific information. In other words, you have a client who is just rambling on and on and on and never answered the question, whereas you can recenter them by saying, "Now, can you tell me again what medications you take?" Validation can validate what the client has said to make certain that the nurse understood the information. It should not be overused, or the client may feel that the nurse is just not paying attention or listening to them. Clarification allows the nurse to gain an understanding of unclear statements the client may have. In other words, you can rephrase something, or, can you say that in a different way so I'm sure I understand what you're saying. However, again, if you overuse it, it can cause the client to feel that the nurse is not listening, or maybe they are not knowledgeable about a topic. Reflective questions or comments will repeat what the client has said and can encourage the client to elaborate. Sequencing puts a timeline to what the client has said and can help us determine a cause and effect relationship between events. And directing questions or comments can elicit additional information about a topic or a new aspect of a topic from a client. Exemplars of non-therapeutic communication. Well, let's move on because we have it right here and I've added a few. This is a failure to perceive the client as a human. This is where the nurse who does this is viewing the client as more of an object of care. We could also be addressing the client as honey or sweetie. That's very demeaning to clients. Always err on the side of formality by addressing a client by their title of Mrs. or Mr. or Ms., etc. Never assume that it's okay to call a client by their first name until they give you permission. Nurses should care for clients as a whole and not just the diagnosis. A failure to listen can cause a client to not feel able to speak freely or completely. We also see defensive nurses because of a lack of confidence causing significant communication barriers. Cliches are stereotypical, trite, or pat answers that suggest a disinterest or can offer false assurances. They can also make generalizations that don't apply to this client. Questions that require only a yes or no answer tend to cut off the conversation. They can also offer a client the opportunity to choose to refuse care. So, for example, instead of asking the client if he would like to take a shower, ask if the client would prefer his shower before or after lunch. This way, you're giving them a choice in when they're going to do it, not as to whether they're going to do it. It allows them some control in their care. Questions that ask why or how can be very intimidating to the client and inhibit communication. Questions that probe for information can make a client feel as though he or she is being interrogated. And if they feel that, they often will stop talking and avoid further conversation. Leading questions can produce answers the nurse wants to hear rather than factual information. Comments that give advice implies that the nurse knows what is best for the client, and it denies the client's feelings or right to make decisions. Judgmental comments impose the nurse's standards on the client and does not promote a feeling of safety and acceptance. Changing the subject can actually stop the conversation, causing frustration or feelings of rejection by the client. Giving false assurance is really easy to do, but it can give the client false hope or make the client feel that the nurse is not really interested in what is going on. And then gossip and rumor. It can be harmless, but more often it will damage the reputation of others and can block team building. So HIPAA, the Health Insurance Portability and Accountability Act, HIPAA. It ensures that clients have the right to see and copy their health record, update their health record, request correction of any mistakes, get a list of disclosures of the information an institution has made for purposes of treatment, payment, and healthcare operations, to request a restriction of certain disclosures. In other words, I don't want you to share this information with anyone unless I give you permission. And it allows clients to choose how they receive health information. Health information can be released for public health issues such as disease outbreaks, infection control, or harmful drugs. It can be released for legal purposes when the information might be crucial to an investigation, can identify victims of crime, abuse, neglect, or domestic violence, or with a valid subpoena. And it can be released to coroners, medical examiners, funeral directors, and to facilitate organ donation. We do consider privileged communication between a client and a doctor to be protected even in a legal setting. And healthcare providers that have a need to know client information in order to provide care for a client are also protected. Or if a client authorizes the disclosure of health information, that will also provide protection. HIPAA can inadvertently be violated in a variety of ways, such as discussing with a coworker who is not involved in the client's care, walking away from a computer that is showing a client's medical information, providing client information to a family member without the client's permission, including the client's personal information on a homework assignment, or using technology without ensuring client confidentiality. Violations of HIPAA can result in legal action. It can result in the loss of a professional license, including a nursing license, and it can result in the loss of your employment. We also need to consider how to communicate with clients that have disabilities or special needs. They require different communication techniques to obtain or convey necessary information. When we're talking to older adults, we have to avoid elder speak, which is the use of diminutive words, exaggerated voice intonation, using a higher pitch or exaggerated punctuation. All of those can indicate that the older adult is not competent. And that's actually a form of ageism, which is discrimination. Clients who are visually impaired, make sure that you identify yourself when you enter a room and let the client know when you leave the room. They can't see that happen. Always speak before touching and always ask permission before touching. Assure the client's visual aids are in place and or that they are clean. And speak in a normal tone. A lot of people, when speaking to someone who has a visual impairment, will raise the volume of their voice because they just they're treating them as though maybe they have a hearing impairment. And we also need to be aware that the client with visual impairment does not see nonverbal communication, so we may have to elaborate on some topics. With the client that has a hearing impairment, gently touch the client or move into the client's line of sight before speaking to get the client's attention. Face the client when speaking and talk in a normal manner and pace, but use simple sentences. Use sign language or gestures or pantomime if appropriate. Assure the client's hearing aids are in and are working if that is part of the client's uh, issue. Write communication down if necessary. And don't chew gum or cover your mouth when talking. A lot of people with hearing impairments may not completely read lips, but they use that to assist them in knowing what the speaker is talking about. Clients that have a physical barrier, sometimes we can use eye blinks or hand squeezes for simple yes or no questions. Provide a paper and pencil or communication board, etc. And don't get frustrated. Make sure you give the client plenty of time to communicate. Clients that have a cognitive impairment, maintaining eye contact is important. Minimize distractions and choices. Keep the communication simple and concrete. Be patient and give the client ample time to respond. After a couple of minutes, if they don't respond, then you may need to prompt them. Clients who are unconscious, even though they are not conscious, they may hear what you say, so be very careful of what is said in their presence. Assume that the client can hear you. Always speak before touching the client and minimize distractions and environmental noises. And then clients who do not speak English, use an interpreter. And this should not be a family member. This should be a non-biased person. Maybe you have an interpreter available within the facility. They do have interpreting services that you can dial on the phone to also assist. Use gestures or demonstrations as necessary. Use a normal tone of voice and simple sentences. Use a language dictionary or translator, and monitor their nonverbal cues. I talked a little while ago about SBAR. SBAR is a tool that uses situation, background, assessment, and recommendation as a template for your communication, especially for like handoff reports or when you are calling the provider. There is an example in your textbook. So handoff will occur when the responsibility for care is transferred from one care provider to another. And the SBAR tool will provide a template for this communication, excuse me, to improve the transfer of necessary information and help prevent omission of information. It's going to help provide more complete documentation. So again, S is the situation. It can also identify the caller, but may contain statements such as, I am calling because I have observed major changes. I have measured the following vital signs, drain amounts, etc. I have the following results to report. Basically, it's going to tell why you are communicating or what problems you have observed and reporting the client's current condition and any interventions that you may have done or medications that you have given to address the situation. B is the background. It will include the client's diagnoses, the admission date or postoperative date, any procedures or treatments that may have been done previously, any previous significant illnesses and or allergies. This would be a great place. Let's say we have a client who is responsive to pain only. This would be a great place to say the client is a type 2 diabetic. A is going to be your assessment. What have you assessed? Such as what vital signs have you gotten? Are there any recent lab results that may support or disprove your concerns? And if you feel that the situation is emergent, speak up. Make sure the provider is aware. And R is your recommendation. You can request advice or specific interventions. And then documentation. We're going to talk briefly about principles and do nots and abbreviations. Documentation is going to be the written or electronic legal record of all pertinent interactions with the client. It will become part of a permanent record. So, first of all, don't put anything in there that you don't think anyone else should be reading. So, principles of documentation, everything in healthcare is going to occur in military time. It should be factual and never contain emotion, the nurse's subjective feelings, or their opinions. It should be concise, complete, current, and accurate. It should also be timely, so it should be completed as soon as possible to the actual time something was completed. If something was forgotten as you're documenting, you can go back and create late entry, and you put that in there, late entry, as part of your documentation. Notes should always be added, such as narrative notes in computerized documentation, should always be added when a client is admitted to a unit, transferred to another unit or facility, discharged, when interventions, procedures, or treatments have been done. When communicating with a provider regarding critical client information, that can be very key to protecting yourself. The provider can always say, well, you never called me, but if you document it every time you attempt to call, then, excuse me, they have a hard time arguing that. Document any change in client status and evaluation of your interventions. If a client states something in particular, document their statement in quotations. Go under the assumption that if it was not documented, it was not completed. I don't care if you complete every assessment the exact same way. If you forgot to document that you auscultated the lungs, you didn't do it, even if you know for a fact that you did. And it's recommended that you only document assessments and interventions that you yourself completed. And before you submit your documentation, read it for accuracy and clarity. So do not use these words in your documentation. Good, average, normal, sufficient. Nurses use measurements. So what is good? What is average? It's going to be different for everyone. Do not use the words appears or seems. It either is or it isn't. Use descriptions. In other words, don't say the client appears to be asleep. How do you know? Maybe they're just laying there with their eyes closed. Maybe they're listening to music or listening to the television with their eyes closed, but they're not really asleep. So it either is or it isn't. Instead, you should say client resting quietly with eyes closed, which could indicate that yes, they are asleep, or no, they are not. If you're doing paper documentation, never erase documentation or use whiteout. You never scribble to obliterate documentation. You draw a single line through a mistake and write error. Then you sign it and then rewrite the entry appropriately. With paper documentation, you should never leave blank lines or spaces. Always put an X in that space and then sign beneath it. On paper documentation, you should always use black ink or the ink that the facility requires. And abbreviations. Only use facility approved abbreviations. If you're uncertain if an abbreviation is approved, spell it out. There are some abbreviations that were common in the past, but they have been determined that they shouldn't be used any longer due to medical errors occurring because of that. So refer to the approved abbreviations and error-prone abbreviations lists in your Blackboard resources and in your textbook.